Again, this is going to be an overview. It's not going to be dig too deep into anything. And then I will try my best to answer questions at the end. I can get change slides. So, epilepsy is a lot more common than people think. It's something we don't talk about very much, like we talk about diabetes and other things. But 1 in 10 people will have a seizure in their lifetime for various reasons. But 1 in 26 people will develop epilepsy, and that's a tendency towards recurrent seizures. Currently, 3 million Americans have epilepsy, 65 million worldwide. And a lot of those are children, so 500,000 children in the US have active epilepsy. And we see a lot of new cases, more than 4,500 new cases are diagnosed annually in children. And it's common to start in children and it's common to start in adults. And if you look at all these other listed neurologic diseases, epilepsy goes well beyond in frequency to those disorders. Worst time changing slides. Um, Truths to common misconceptions. There's a lot of things that are said about seizures. One of the big ones is you can't swallow your tongue. In fact, we recommend not putting anything in somebody's mouth during a seizure because you're more likely to break the person's teeth than you are to help them, even if they're biting their tongue or biting their cheek. Epilepsy is not a contagious disorder. Everyone who has a seizure does not have epilepsy, and that's not always a convulsion. And we'll talk about that a little later. Some people are aware or partially aware during their seizures, but a lot of people are unaware and don't even remember having a seizure. And epilepsy is not due to a mental illness. Now, we know people with epilepsy are at higher risk for anxiety and depression, especially in the teen and early adulthood years, but it's not due to those issues. So there is a specific diagnosis for epilepsy, and there's 2 ways you can be diagnosed. One is to have 2 unprovoked seizures that occur greater than 24 hours apart. And unprovoked just means it wasn't from an illness or you didn't get hit in the head or something like that. Or a person with an unprovoked seizure with a high probability of future seizures. And that could be due to a certain genetic disorder that they have, or typically findings on their brainwaves that suggest they're at a high risk. So a seizure is an event, and the true definition of seizure is the sudden onset of a disease or condition. So it doesn't even relate to the brain, but we use it when we talk about epileptic seizures or seizures affecting the brain. Epilepsy is the disorder of recurrent unprovoked seizures. That's really what we're talking about. Most people, 70%, don't have a clear cause that we know of for epilepsy. And we're thinking more and more that many of these are genetic, even though we don't know the genetics yet. We know a lot of the genes for epilepsy. I think it's over 1,300 genes now that can cause epilepsy. But there's probably 100,000. We don't know. So 30% don't have 30% have a known cause, and those can be lesions of the brain, other ones you're born with or ones you develop, like tumors, stroke, or any kind of trauma, toxins, infections of the brain, and again, those known genetic causes. So not every seizure is due to epilepsy, and if somebody has a first-time seizure, it's a medical emergency. We don't know why they're having it. Could they have a tumor? Could they have a hemorrhage in their brain? We don't know, and they need to be evaluated. Once the diagnosis is made, unless there's something unusual to the seizure, which we'll talk about later, we don't have to consider each seizure an emergency, and they don't have to be seen in the emergency room. So an epileptic seizure, some people call it an electrical storm in the brain, but it's an excessive electrical activity in the brain. Most of the time when we look at brain waves, they're chaotic. There is some rhythmicity to it, but it's mostly chaotic. Seizures are rhythmic and evolve, and it's much higher in its electrical charge in the brain. So it kind of takes over the brain, either all over or sometimes in one area of the brain, and it can alter movement, sensation, behaviors, and awareness. And it can spread through the brain, and so you can get different symptoms as it spreads to different areas of the brain. And there's two basic types of seizures. There's generalized and focal. And focal we used to call partial because it's French for focal. We used to use French words for everything. Generalized seizures affect both sides of the brain at onset. So when we're looking at it on their brain waves, it looks like it starts everywhere. And it affects both sides of the body when you look at the person having the seizure. A focal seizure begins in one specific area. Now, it can spread over one hemisphere and it can even jump to the other hemisphere, causing a generalized seizure. But we call that a secondarily generalized seizure because it started as a focal seizure. Um, Inside the world of generalized seizures, there's different types. There's the tonic-clonic, which is the one most people think about when they think about a generalized seizure. There's absence or absence, if you're going French, tonic, atonic, and myoclonic. So tonic-clonic, and a lot of people, this is what you see on TV and things, are the big seizures, the major motor seizures. And there's two phases. There's a tonic phase, and that's when the patient gets very stiff. People can even break bones during this. This is when they bite through their tongue or their cheek. Um, Sometimes there's trembling. It's not like the clonic or jerking phase of the seizure, but you can tremble during the tonic phase. And then you see the clonic phase, which is the jerking, and it can be rhythmic or semi-rhythmic. And those are the big jerks of the extremities and the body. Often when we see that, it suggests that the seizure is winding down. Not always, but that usually means that things are coming to a close. And then that clonic activity gets slower, and then the seizure ends. After a seizure, people complain of headache, muscle soreness, and disorientation. We call that the post-ictal state or the after seizure state. And that can last anywhere from a few minutes to a few hours. So during a tonic clonic seizure, sometimes during the tonic phase, you'll hear a cry. It's a very unusual cry because it's actually the chest becoming rigid or tonic, and it's forcing air through vocal cords that are tonic. They're really tight. So it's a very unusual sound. And then they can fall and then get the rigid tonic phase. They lose consciousness because it's affecting both sides of the brain. And then they can have the trembling that leads into the jerking. They can have trouble breathing. Your diaphragm cannot be involved in a seizure, so you still can have air movement, but the person can look very pale or dusky. They can bite the tongue or the side of their cheek, and they can lose bladder or bowel control. And that can occur during the seizure, sometimes in that post-ictal state when their body relaxes. Now, the absent seizures, those can be very subtle, and there's some that start in childhood, and then there's some that can start later on in life. These tend to be very brief, seconds, and the person will stare off into space. It's usually not just like a daydream stare. Usually they kind of have this look like I always say it's like the lights are out. They often have some eyelid flutter with it. Um, and it can occur multiple times per day, sometimes hundreds of times per day. So they can be easily missed because they can be short unless you're looking at the person or you're interacting with the person. And it's often confused with daydreaming or lack of attention. Some of these children are diagnosed with attention deficit disorder. A lot of times it's a teacher in these children that have seen another child with this type of seizure, and they tell the parents, I think he's having staring seizures. Tonic seizures are just like what we said with the tonic-clonic, but they don't get the clonic activity. The pure tonic seizures typically last only seconds. They most often occur during sleep, but if they occur during wakefulness, they can cause you to fall suddenly and often lead to injury with the fall. Then there are the atonic and the myoclonic. Atonic is the opposite of tonic. It's the complete loss of muscle tone. And you either, if you're in a chair, your head may drop forward. If you're standing, you suddenly fall to the ground. Some people retain awareness during it. They can also have injuries. It can occur without warning. There are rare epilepsies that can occur with if you make a sudden noise or something, they'll suddenly lose muscle tone. Then there's myoclonic, and that just means muscle twitch. So it's a sudden, brief twitch of the body, and that can, in and of itself, be a seizure. Usually, they're aware during it. Sometimes this can actually cause you to fall if it's a very big one that affects more of the body. And they can cluster, so you can have lots of them in a row. Um, they can be associated with other seizure disorders, and there's a classic one called juvenile myoclonic epilepsy, which is a generalized epilepsy that they have this type of seizure often in the morning, and then they have the bigger tonic-clonic seizures at other times. Now, focal seizures, there's two basic types. There's impaired awareness and unimpaired, and the name recently changed to impaired consciousness and unimpaired consciousness. Um, it can have weird symptoms. They can have motor symptoms where you fall. You can have jerking of one side of the body or twitching of the face or eyelid. But sometimes they'll have unusual sensations um, or visual changes. Sometimes they smell funny things. They can have changes in their emotion. Sometimes they get feelings they can't describe. So with impaired awareness, they can stare. Sometimes they'll walk and look like they're doing semi-purposeful things. Um, they can make chewing movements when they do it. Again, sometimes their eyelids will flutter, sometimes one side, can be both. They may seem like they are aware of what's going on around them, but they are unaware. And they can appear very confused. Often with the side opposite of the seizure, they'll pick at clothes or objects. And if you try to restrain them, sometimes they'll push back. Now, with focal aware seizures, um, again, these can be motor. They can affect, and you can have rhythmic activity of the arms, face, legs, um, or they can describe weird sensations of tingling, and it can move. The tingling can move like up the arm. They'll hear things, smell things, taste things, see things. Some describe an unusual rising sensation in the body. They can have deja vu or hallucinations. Sometimes it shows up as fear. And a lot of times they just can't explain it. They say, I get this feeling, it's like this, it's like that, but it's not that. It can be very difficult to describe it. These usually last seconds, typically less than a minute. And sometimes they will have these and also have the unaware seizures, and these can represent what we call an aura before a focal unaware seizure. I mean, these can be confused. Most often, when patients come, they're told they have a psychologic problem causing these. But some people think it's kind of a mystical thing, or they're told that they're making up their symptoms or acting out. But epilepsy is a spectrum. It's very different, um, especially in children. I always say as children grow and change, their seizures grow and change. So when new things come up, or if there's an evolution in what their typical seizures are, you have to keep looking into things and knowing what seizure, what's not seizure, what to treat, what not to treat. And it's different from person to person. So triggers and treatments. Um, Half of people who start a seizure medicine well controlled. They take their medicine every day and they don't have any seizures. About a fourth um, have control, but they still have breakthrough seizures even when they're doing everything right. And then there's about a third to a fourth that continue to have seizures despite multiple different medications. And we call them intractable or refractory or drug-resistant epilepsy. And those are the ones I typically see the more difficult epilepsies. And there are medicines. Again, medicines in most patients can help either get rid of their seizures or reduce them significantly. We call them anti-seizure medicines. We used to call them anti-epileptic medicines, but they're really symptomatic treatments. They're not fixing the problem, the epilepsy. They're keeping the seizures at bay. And a lot of patients are on more than one, and different seizure medicines do different things in the body. So sometimes you'll have medicines that complement one another that get better seizure control. Um, there are seizure triggers. The big one is they didn't take their medicine. Even the best people in the world with the best memories will forget their medicine from time to time because it becomes such a common thing that they do that they remember the 100 other times they took the medicine and swear that they took their medicine that day. So we teach a lot of things to teach patients how to remember to take their medicine. Lack of sleep, big trigger. Alcohol and drug use, and illness. These other things are less likely to cause seizures, but are things that we think about, like stress, hyperventilation, hormonal changes we see during puberty. Sometimes you'll see increased seizures. Then there's these other less common things like flashing lights. There are specific rare epilepsies that can be flashing lights. But this overall change in health, we know a healthy lifestyle is better for seizures. And when that changes, sometimes you'll see more seizures as well. Now, there are non-medical treatments for seizures. And I run the ketogenic therapy clinic at Duke. So we do the ketogenic diet in a lot of people, and it's a medical treatment. It's not a natural treatment. It's very unnatural. In fact, we have to monitor people with laboratory studies every 3 to 6 months to prevent serious side effects. And with it, we're trying to convince the brain to consume ketones over glucose. And to do that, you give somebody a lot of fat, which is turned into ketones, very, very low carbohydrate, and then enough fat so they don't break down muscles. Um, how ketones help seizures, we don't know. But they can reduce seizure frequency, and some children go seizure free. Often they still stay on some medicines, but they can be have significant improvement with this. It's more common in childhood because younger children, it's easier to switch to this diet, which sometimes can be difficult to eat on a regular basis if you've had a high carbohydrate diet like we have in our country. Um, and it requires a strong commitment from the patient, the family, school, everybody they come in contact to when they have food. And again, there's a lot of monitoring involved. So it's a difficult thing, but it can be very helpful. Then there's surgery, and there's different types of surgery. There's resection where we do a big evaluation. We find an area of the brain where the seizures are coming from. So these would be focal seizures. And then you take that tissue out. And that can be curative. If we get all that tissue out, it can be curative. Now, there's risks to that. I mean, you don't want to take out a piece of brain that helps you talk or move or something like that. Then there's disconnection procedures. And there's different types. There's some where we disconnect large areas of the brain that can cure seizures. There are other things like something called a corpus callosotomy, where we cut the connections between both hemispheres of the brain. And that's palliative. They still have seizures, but they don't cross the brain, so they don't fall down with their seizures. They'll keep the other, if you can keep one hemisphere from seizing, having it spread to that hemisphere, you can maintain awareness and typically your posture and not fall. And then there's neuromodulation, where we use devices that use electrical impulses to help seizures. The most common one of those is the vagus nerve stimulator. And this thing, you go in for the first surgery, a little day surgery. They do a little incision in the neck, and they connect these little wires to the vagus nerve on the left, and then they do an incision in the chest and insert the little device, and then they tunnel the little wire with little loops. So if you have a quick stretch of the neck or you grow, you're not going to break the wire. And it does three things. The main thing is what we call its regular settings, where it's constantly throughout the day, on and off, sending a little signal to that nerve. And this vagus nerve, it goes down to the body. It controls part of the vocal cords and things. But the way they arrange the wires, it sends most of the signal up to the brain. And it actually will activate several areas of the brain. We don't exactly know how that helps seizures, but it does. And so we're using the nerve as a conduit, a wire to the brain. This is not a quick fix. You've got to commit to this one because it can take months to get to the right settings because it can be uncomfortable at first, the little electrical impulses. And we know now that over years of having the device, seizures can continue to improve. But usually people still stay on medicine even though this helps. Um, Now, if you notice, it's sitting pretty close to the heart. So it has a little sensor in there. Most people, 80 plus percent of people, when they have a seizure, their heart rate goes up very, very quickly, quicker than if you were to suddenly run around the block. And when it detects that, it says, well, this could be a seizure, and it sends an extra signal to the brain that could shorten the seizure or stop the seizure. Now, you can't count those all as seizures because we know if you get scared, if you have a panic attack, it can make your heart rate go up that fast. And we know that later in sleep, so probably during dreams, it also can happen. So sometimes that'll go off at other times. So it's really, we can see how often it goes off when we interrogate the device with this little wand. But we always have to remind parents that that's not every time they have a seizure. That's every time their heart rate went up very quickly. And we can set all those parameters. Then there's the magnet, where if you touch a magnet to it for a strong magnet for a second and then take the magnet away, it'll send an even bigger impulse. So you would do that if somebody's having a cluster of seizures or a big seizure. And it can shorten the seizure or the postictal state and make them wake up faster. Out of all of these, number one, the regular stimulation is what seems to help the most. The magnet helps some people, but doesn't help as many people as we had hoped it would. And again, they usually have to stay on a seizure medicine. I've never been able to get people off all their seizure medicines, but sometimes we can get to lower doses or fewer seizure medicines. Deep brain stimulation. Now, this is one that's approved in adults. Um, we sometimes can get it improved in kids. And remember, I said we use the vagus nerve as a kind of a wire to the brain. This one we go directly. And you drill a hole on either side of the skull, and you put these electrodes deep into the brain in something called the thalamus. And there's different areas of the thalamus that, for different types of seizures, that we stimulate. And they have a similar device that's implanted under the skin in the chest. Actually, now they only have one, they don't have the two. And it sends out little impulses that can reduce seizure frequency and severity. And this can be used for focal seizures and generalized seizures. RNS, or response neurostimulation, is another one. It's only approved in adults. Again, we can sometimes get it approved for children. This one is very individualized. So we monitor, and what our goal is when we monitor these patients, we want to find an area of the brain where the seizures are coming from. And it can be more than one area because this device has two wires, so it can do two areas. And you can either, if it's right on the surface of the brain, you can use one of these little pads, or if it's deeper, you can use one of these needles that go into the brain. And this device is actually attached to the skull, and it has a little EEG machine in there, and it's constantly monitoring your brain waves. And everybody's brainwaves are a little different, and everybody's seizure onset is a little different electrically. So this will learn what your seizures are like, and it'll send a little electrical impulse to this area and stop the seizure. You have to have a very specific area of the brain where the seizures are coming from. Now, if it's an area that, again, we can remove safely, often we'll resect that area because that can be curative. But let's say it's over the area of speech. You wouldn't want to cut that out. So often that's when we're using the RNS. And you can have up to two of these at the same time. So you can actually cover four areas of the brain. They're sometimes now using one of the wires deep in the brain to act like a deep brain stimulator. And there's a newer version coming out that actually has four wires. So technically you could go to 8 areas in the brain. So there's a lot going on in the world of RNS. So seizure first aid. And a good way to remember is trust. So you want to turn person on their side, and that's really so when they often salivate a lot, or they can vomit with the seizure or after the seizure, that the fluids come out, it doesn't go into their lungs. You want to remove objects from around them in their glasses. You want to make sure they're safe and their head is resting on something soft. And stay calm and stay with the person until they start to wake up. And if you can, time the seizure. It's often hard to time a seizure. Often we don't see the beginning of a seizure, but try to get as much information as you can on the seizure. because that can be helpful. So for tonic-clonic seizures, the generalized seizures, protect the person from hazards. Check for a medical indicator, so a bracelet, a necklace, because remember, if they don't have epilepsy, you'd want to be calling 911 and getting an ambulance there. After the seizure, make sure that they're safe, make sure they're breathing okay. Wait till they wake up. Provide them with emotional support, and again, document what you can for the seizure because that can help the family and the neurologist. Focal seizures, it's about the same, except they may not be laying there. They may be walking around. So you want to do the same sort of things, but you may be following the patient around the room, knowing that they could get combative if you try to restrain them. You just want to make sure they're safe until the seizure passes. So when is a seizure is an emergency? First time seizure. They have no, if it's somebody you meet on the street for the first time and they have no identification to suggest that they've had seizures before, medical emergency. Seizures lasting greater than 5 minutes. Repeated seizures where you don't regain consciousness in between. Um, Longer seizures or a change in seizures in somebody who already has epilepsy because that could suggest something else is going on. Of course, if the person is injured with the seizure, or if they have diabetes or is pregnant, because diabetes can be a trigger for seizures, that needs to be addressed. And we know that a seizure during pregnancy can affect the developing fetus. Any seizure that occurs in water, because they can look fine and have pulled water into their lungs and they can actually develop pulmonary edema later. So they need to be assessed. And if they're not breathing normal, even after the seizure. And a lot of this will be in the seizure action plan that we'll talk about at the end. So seizures in water, what do? Get them out of the water. Make sure they're safe. Follow what's in the seizure action plan. Do the trust thing. And again, if it's in the water, whether it be in a pool or whether it be in a bathtub, 911. So seizure safety at home. I always tell parents, take a shower, not a bath. If you have one of those little push drains, little push things that plug the drain, take it out. I had a patient who passed away when she fell and had a seizure and her head closed the drain and the tub filled. Don't lock the door. Put an in-use sign on the door handle. Let people know you're about to go take a shower. And use a shower curtain. So the problem is with glass is that if you were to suddenly fall, you could break the glass and have injury from that. There are seizure when you're asleep, seizure alerting devices. They're really only good if you have rhythmic movements. So people with staring seizures and things are often not very helpful. But if you do have tonic-clonic seizures where there's trembling or there's clonic activity, they can be helpful to alert that there's a seizure going on. There's also the cameras that can detect rhythmic movement. Bed frame should be lower to the ground. A lot of people just put a box spring and mattress on the floor, no top bunks. Consider where furniture is placed.
Webinar. A webinar.
You want
Webinar.
you wouldn't want bedside tables or something that could trap somebody if they were to fall out of bed. And you want to use tightly fitted sheets. There is a risk of getting caught up in the sheets. It's a rare complication, but you want to avoid anything that could affect somebody if they were to have a big seizure when they're asleep. In the kitchen, one of the things I always tell patients is that what would you not want to be doing or where would you not want to be if you lost awareness for a few seconds? One is over a hot stove. So if you use a microwave, if you can, use back burners, not the front burners. So if something were to happen, you'd be less likely to hit it. A food processor over knives, and then shatter-resistant glasses and plates and things in case you do have a seizure. And then in the neighborhood, if you're going to go somewhere, Let them know where you're going. Let them know when you're going to come back. Better yet, take somebody with you. So if you're going to go on a little walk, let everybody know. Wear your medical alert indicator, whether it be a bracelet, a necklace. Some people have the things that go in the laces of their shoes now. When biking, wear a helmet and never ride near traffic. And I always tell kids, don't climb anything higher than yourself. Don't climb high objects. Playground equipment, which is usually on wood chips or that soft rubbery stuff, is probably okay. When I grew up, everything was on concrete, um, but so they can still play in a playground area. Rescue medications. Um, we really didn't have rescue medications until about the late 90s. So for a long time, we had nothing. And these are acute treatments. These do not replace medicine, daily medicines. You treat prolonged seizures, seizure clusters, or unusual seizures. And one of the in the seizure action plan is when to use these medicines. Um, in some states, they can be given by non-medical professionals, so a teacher or something. But in some states, it's got to be given by a nurse or a physician. Um, Currently, all the emergency medicines we have are benzodiazepines, which work very quickly, but they can also affect breathing. They're dosed as not to do that, but especially if they're receiving a first dose, you want to watch them and monitor them after the seizure to make sure that they're breathing okay. The first one we had was diazepam rectal gel or Diastat. Um, this one was rectal, so it was more complicated to give in the schools. Um, this used to be the only one. This is approved at age 2 and up. Um, so we didn't have anything else until you got to be 6. But now, um, this intranasal diazepam or Valtoco was recently approved down to 2 years of age. So the rectal one is kind of moving away, and we're moving kind of exclusively toward the nasal spray. It's just easier to give. You can see that it goes in. Where in the rectal, sometimes if some comes out, it's hard to tell. You also can do it in public without worrying about all those other issues. Um, and it's a single spray. As you get bigger, because of the volume, so in adults, it's usually one spray in each nostril, while in smaller children, it's just one spray in one nostril. And it can work as quickly as the rectal because the mucosal membranes inside the sinuses absorb these kind of medications very quickly. There's another one called Nasalam, which is midazolam. It doesn't last as long as diazepam, but can work as quickly. This one's really only approved for seizure clusters. In fact, it's the only one that's specifically approved for seizure clusters. It can help with a prolonged seizure, and we often use it for that, but it's really for seizure clusters. The other two, the two diazepam, the rectal one and the other nasal one, Valtoco, you can repeat after 4 hours. You can repeat one of these doses after 10 minutes if the seizure cluster continues. Which is better? I don't think there's one that's better than another. Some insurances are picky which one you can get, though. So the seizure action plan, um, it's really helpful, and it's helpful for schools. It's helpful if you're going to go to somebody's house, if you're going to be with friends, wherever you go, because it says what do my seizures look like? What are potential triggers for my seizures? What to do when I have a seizure? What medicines can you give? If I have a device like a VNS, what to do with the magnet to trigger the device? It includes all that information in a very simple way. Most schools request this, but again, if you're an adult, could have this at work. If you send your child to a sleepover with somebody comfortable that they potentially could have a seizure, you can send it there. So it's a very helpful thing to have. And we're the Epilepsy Alliance of America, and you can see we're expanding mostly on the east side of the country, but we're heading west. Any questions? And hopefully I can answer them.
Thank you so much, Dr. Rathke. That was great. Very informative and covered a lot of ground. But if there are any questions, now would be a great time to share them either in the chat, or you can turn your camera on and come off mute. I do see one in the chat about what to do for a seizure on a bus, perhaps maybe a school bus or a public bus.
You would do the same sort of things, the typical seizure safety things, usually lay them in the aisle on their side. Um, in If your child is going to school on a bus that's specifically for children with seizures or wheelchairs, things like that, often those bus drivers are more trained. In fact, a lot of them are trained in using, in our county here in North Carolina, they're trained in using the nasal spray. So they could use it if they identify a seizure. Um, but otherwise, you would just do the basic um, first line seizure care.
Another question is, when do you consider a cluster seizure that would necessitate rescue medicine?
It's hard to say. Now, there are some children that have clusters of seizures, and say children, I mean adults too, but I do pediatrics, so it's always children and kids with me. Um, they'll have clusters in the morning. That's their norm. And often we don't treat those because that's just what they have. But if it's abnormal, if they're not completely coming back in between the brief seizures, or if they've never had a cluster before. So, what is a cluster? A cluster is two or more seizures that occur in a short period of time. There's no written time limit for what a cluster is. But I usually think if you have more than one in an hour, and that's atypical for you, that's a cluster. Often they'll have several in an hour in the kids that normally cluster. Um, so it's really if it's unusual or if it seems like it's long, I would treat.
And then somebody else would like to know about specific response techniques for infants.
I mean, it's the same. It's laying the child on the side. One thing a lot of people do with infants, because you can pick them up, is they pick them up and put the child on their shoulder. And you don't want to do that, even though you feel like you're helping, because if they do vomit, which can happen with a seizure, or they salivate a lot, it can go directly into their lungs. So you want to lay them on their side and let the fluid clear out. Um, it's harder because we don't have an emergency medicine for infants. So if the seizure does go long or it is a cluster or something unusual, then really you have to call EMS. They can use medicines, typically IV, to help stop the seizure. We just don't have anything yet for that age of child.
And then we covered seizures on a bus, but somebody else would like to know anything different that should be kept in mind for seizures in a wheelchair, and should you remove them from the wheelchair?
That's hard. It's if they're having a tonic-clonic seizure, um, typically we'd like to lay them on their side. If it's a myoclonic seizure, a quick atonic seizure, you usually don't have to. Um, but if they're having a bigger seizure, you really want them on their side because aspiration is one of the um, worst side effects of having a seizure. I mean, they end up in the hospital with pneumonia and things. So if you can, you try to get them and lay them down on their side.
And then a couple of these questions probably a little bit broader than we're able to cover in this time and in this format, but questions about PNES and LGS. So any quick thoughts or considerations that you would want to share with the group right now on
Well,
those two
LGS,
conditions?
Lennox-Gastaut, which is one of the developmental epileptic encephalopathies, um, is a seizure disorder where they have multiple seizure types, um, intellectual disability. Um, it can be caused by many things, so it's not a single disorder. It's a clinical diagnosis. They can be very difficult to treat by definition. There are newer medicines that can be effective. They often end up on multiple medications. We treat a lot of them with ketogenic diet. A lot of them receive VNS, and all those things can help, but often they still have seizures, and we don't have the magic bullet yet for those types of patients. So we try to reduce the seizure frequency and severity as much as we can with these other things. Um, Non-epileptic PNES, that's difficult because half the people with PNES also have seizures, epileptic seizures. So it makes it very difficult. We're often monitoring those patients, and we in the hospital with EEG, so we can talk to the family and say, okay, when they do this, this is not an epileptic seizure, and this over here is an epileptic seizure. Um, because you don't want to miss epileptic seizures in somebody with PNES, but you also don't want to chase PNES with anti-seizure medicines with potential serious side effects. So you have to kind of figure out what's what. There are different therapies for PNES. We're getting better and better at those. In fact, if you go to websites with for a functional medical neurologic disorder (FND), there are a lot more resources now than there were 5 years ago for these disorders. So there are a lot of options for patients with PNES.
And then I think we've got a couple more questions here, and then we can probably wrap up. Any thoughts that you would like to share with the group on treatments that involve cannabis or THC?
THC, we don't know. We know in rat studies that high levels of THC actually worsen seizures. That being said, a mixture of CBD, so we know CBD is what we use, and there's actually pharmaceutical CBD for seizures. With smaller amounts of THC, may help seizures in different ways. There's a lot of research right now on that. So in the next few years, I think we're going to see a lot of different therapies using cannabis. I use CBD a lot, but it has negligible amounts of THC. We know high levels, though, of THC are pro-epileptic. They can cause seizures. But again, that mix with the lower levels of THC may be helpful. We just don't know what level and all that yet. So in the future.
Okay. And then Carson would like to know if a child experiences a head injury and then experiences rhythmic seizure-like movements while unconscious, would you still recommend turning them on their side as opposed to holding them C-spine?
That's hard. If it is a secondary trauma like that, you always think C-spine first. So with that, you'd probably go protect the C-spine because that would cause bigger problems than if you inhale some saliva. We know with head injury, you can make seizure-like movements without it being an epileptic seizure, meaning abnormal electrical activity in the brain. But we know with trauma, you can also immediately have trigger an epileptic seizure. You can, even though you don't have epilepsy, I'm saying epileptic because it's electrical, and you don't know. But C-spine first, because when they say ABCs, airway breathing, it's CABC. There's always C-spine first, because you don't want to. If you don't know I mean, if it was a simple head bump, you're probably okay putting them on the side. Some people will faint with head bumps and they'll have seizure-like activity. But if it's a traumatic injury, like say a football player or something like that, yeah, you'd want to protect your C-spine.